So today's topic is heart block. It's a very important concept for both PLAB1 and PLAB2. Let me explain you how they ask heart block in PLAB1. They will often give you symptoms like a dizziness, fainting attack in the stem, and an ECG will be given for you, showing heart block. So your duty is to find out the heart block and management. Some cases management is none, you don't do anything. Sometimes the management include giving atropine and using pacemakers. We will discuss these in detail. And when it comes to PLAB2, it's more of it become even more practical. The exam is, as you know, it's a consultation based exam. So you are here, the patient is here, and the doctor will be here assessing you. So this is a patient will give you history like, doctor, I had a disease spell, doctor, I'm experiencing frequent fainting attacks, etc., etc. And as a doctor, you need to request ECG, and the examiner will hand it to you, the ECG. And from there you need to recognize the heart block and manage the patient. It's a live situation, guys. Everything happened really in front of the examiner, and you have a real patient as well. Okay, so this heart block is important in terms of PLAB1 as well as PLAB2. When it comes to heart block, we have first degree heart block, then and we have a second degree heart block. Second degree heart block, we have Mobitz type 1 and Mobitz type 2, and there is a special type as well. Okay, there is a special type called as high grade heart block, which include 2 is to 1 block or 3 is to 1 block. Okay, so second degree heart block, for the purpose of the exam, you have Mobitz type 1 and Mobitz type 2 in second degree heart block, but there is a special type as well. Okay, and we have a complete heart block. We have complete heart block. So we have complete heart block, also called as third degree heart block. Okay, so we have first degree, second degree, two types, and third degree heart block. So let's go one by one. First one is first degree heart block. First degree heart block, it means there is prolonged PR interval. Usually, heart block means, what do you think of by the term heart block? Some of you might be thinking missing of QRS complex. But here, the QRS complex is present. Every P wave is conducted to ventricle and producing a QRS complex. Every P wave followed by a QRS. But the problem is conduction. The conduction is slow. The conduction is slow. It takes a lot of time for the it take a lot of time for the impulse to reach the AV node. See, the impulse started at SA node, but it takes a lot of time to reach the AV node. So that causes prolonged PR interval. So it just means that there is prolonged PR interval and there is no missing of QRS complex. First of all, what is prolonged PR interval? PR interval in an ECG means it is the distance between the starting of P and starting of QRS complex. So this distance, and it is usually between 3 to 5 small box. 3 to 5 small box means 5 small box contributed to one big box. So 3 to 5 small box. One small box represent 40 millisecond. Sorry, yes, 40 millisecond. So 5 small box means 5 into 40 millisecond, which is approximately 200 millisecond. And 3 small box means 120 milliseconds. So usual the normal range of PR interval is between 120 to 200 millisecond. If it is more than 200 millisecond or more than 5 small box, then we call it as prolonged PR interval. If this is present, then we call this as first degree heart block. Remember, there is no missing of QRS complex. All right, so let's look at ECG. So what you can see here is that every P wave is followed by a QRS complex. P wave, QRS complex. There is a P wave, a QRS complex. Like when you look at, do you think there is any missing of P any QRS complex? No, here is a QRS complex, one, two, three, four, four and a half box, again a QRS complex, half, one and a half, two and a half, three and a half, four and a half box, again a QRS complex. So there is no missing of QRS complex. So it's not going to be second degree or third degree, it's going to be first degree. And to confirm that, let's look at the PR interval. So starting of the P and starting of the QRS complex, so this is the distance. I told you that it should be more than 5 small box to call it as a, what, to call it as a prolonged PR interval. To call it as a prolonged PR interval, it should be, this distance should be more than 5 small box. So let's look at this ECG over here. So this itself, one, two, three, four, five, this itself is 5 small box. So 5 small box plus one, two, three, it's almost 8 small box. So it's prolonged PR interval, and there is no missing of QRS complex. Let's, if you want to confirm it, let's look at another PR interval. So here it start the P, here it starts the QRS complex. So this distance again, it's going to be 5 plus 3, it's going to be 8 small box. So PR interval is prolonged equal, but remember there is no missing of QRS complex. So this is type 1 heart block, and we don't, there is no treatment needed for this unless the patient is having any symptoms. So that's about the first degree heart block. There is QRS complex present. Remember that. Okay, now we will go to second degree heart block. Second degree heart block, I told you there is no QRS complex. And I also mentioned to you that there are two types. That is, we have second degree Mobitz type 1, Mobitz type 2, and special type. So what is Mobitz type 1? Mobitz type 1 means there is missing of QRS complex. There is missing of QRS complex. But with that, if you notice, there is prolongation of this PR interval, progressive prolongation of PR interval before missing of a QRS complex. Maybe let's say this is uh, 3 small box, this PR interval, here it become 5, here it becomes 7, here it become 9. After that, there is missing of a QRS complex. Again, the normal 3, 5, like that. Okay, so there is a missing of QRS complex. With that, there is prolongation of PR interval. Let's look at an ECG. Okay, so this is a second degree heart block, and it's Mobitz type 1. Okay, so let's look at the ECG. Yes, as you can see, this is, the distance between this R and this R is a compared to other, it's large. So yes, here is a heart block. This P has not converted to QRS complex because there is a block. So here is a block. Now let's see the PR interval. So this here is a P, here is starting of QRS complex. So this is the PR interval. It's prolonged almost 8 small box. Now here we have, after that there is a T wave, and here P, and this P wave not converted to a QRS complex, so there is a missing. Again here normal PR interval, and this PR interval is prolonged here. See here, it's a bit prolonged. Again here, it's prolonged more more than this one. It's getting prolonged compared to this, compared to A PR interval, B PR interval is what? It's large. If it is 8, if it is 5 small box, this is almost 8 small box. And again, see here, here is a block. So there is progressive prolongation of PR interval before a QRS, before a missing of a QRS complex, and this is called type 2 heart block. And what if the case there is missing of QRS complex, but there is no prolongation of QRS, no prolongation of PR interval before missing of QRS complex. Let's see an example. Okay, okay. Here can you see? This is a classical example of Mobitz type 2 heart block. See, this is the PR interval, and here this is the PR interval. Here this is the PR interval. So here the PR interval is same, but there is a missing of QRS complex here. This P wave is not followed by a QRS complex. So there is a missing of QRS complex. There is a missing of QRS complex, but there is no prolongation of the PR interval. The PR interval is same. The PR interval in A and B and C all are same, but there is missing of QRS complex. This is called second degree Mobitz type 2 heart block. Okay, and in Mobitz type 1, just prolongation, further prolongation missing. See here, this is a PR interval, this is a PR interval, this is a PR interval, and missing prolongation. A, if you take A B C, the PR interval is getting prolonged, and then there is a missing here. PR interval in A B C are same, and then missing of QRS complex. So that is Mobitz type 2. This is Mobitz type 1. We do have another type of Mobitz hard block, another type of Mobitz 2 hard block. Mobitz 2 hard block, that is called high grade block. One of an example is 2 is to 1 block. This is clearly mentioned in your keys, PLAB keys. So I'm going to explain what exactly 2 is to 1 block is. So from the tips that I have mentioned earlier, you can see here is the missed QRS complex. Here again one more missed QRS complex. This is P, this is T, this is another P, here is a missed. Again here QRS complex, here T, here P wave again missed. So if you apply our tricks over here, this is the PR interval, and that is before the missed beat. This is the PR interval before the missed beat. Since these two PR intervals are equal, we would think that this could be 2 is to this could be Mobitz type 2 block. But unfortunately, we do not have other waves to see whether there is any prolongation of this PR interval or not. See, here you have a PR interval, but you don't have any idea of the PR interval here. In fact, we need to compare each consecutive PR interval to come to a conclusion that there is prolongation of PR interval or there is a fixed PR interval, but we don't have any of those details here. Again, if you look at here, this PR interval, again, there is a missed beat, but you don't have any other information, any other PR interval information. What is the PR interval over here? You have to compare these two, then to come to a conclusion that this is Mobitz 1 or Mobitz 2. See, the trick itself will not tell you that it is Mobitz type 1 or type 2. You need data that shows that there is progressive prolongation of PR interval or there is fixed PR interval. In this case, you don't have any enough data because every QRS complex is followed by one P, one extra P that is not conducted, one block. Again, you have one PR interval. Again, you have one block. Again, you have one PR interval. So you don't have any consecutive PR interval to compare. So, but the PR interval here is constant. PR interval before and PR interval after the beat is constant. So we classify this as Mobitz type 2. So this type of conduction 2 is to 1 block, this is a type of conduction called 2 is to 1 block, where every second p wave is conducted as qrs. So 2 p wave is needed for one QRS to develop. So this is 2 is to 1 conduction. Similarly, there can be 3 is to 1 conduction like that. 1, 2, 3, 3 P wave is required for one QRS to develop. So this is called 3 is to 1 conduction. All these, we don't have consecutive PR interval to compare. We need two PR interval to see whether there is any prolongation of PR interval is there or not. We don't have this. So this type of conduction is called high grade block, right? And it is a type of 2 is to 1 block. And this 2 is to 1 block, this is a type of a variant of Mobitz type 2. So second degree hard block, we have Mobitz type 1, Mobitz type 2, and high grade block, which is considered as a variant of Mobitz type 2. One example is 2 is to 1 block, 3 is to 1 block, and so on. Next, we will discuss about third degree hard block. Third degree hard block is also called as complete hard block because none of the impulses generated from the SA node will reach the ventricle. All gets blocked at the level of AV node. So what happened is the atria will beats according to the impulse generation from the SA node. But ventricle will also beat, but it is not because of the impulses from the SA node. It beats because of escape rhythm. What is escape rhythm? It is the impulse generated by a part of ventricle or his bundle, any structure below the AV node. If that develops impulses, it is called escape rhythm. So it is due to escape rhythm. Definitely SA node is the one that beats faster. So the atrial rate could be, let's say 70, but the escape rhythm, that is the impulse generated due to structure below the AV node, could be from his bundle or from the ventricle, it's definitely going to be lesser than the SA node. So ventricle may beat at the rate of 40, but the ventricular rate is always regular. So the QRS will happen at a regular interval. Similarly, SA node will beat at a regular interval. So the P wave is going to be regular and will be regular. By that I mean it happened at a regular interval, but there will be more p waves, number of p waves would be more than number of qrs complex, because the ventricles beat uh, at a rate lesser than the atrial rate. Okay, but there is no relation between p and qrs, because P wave is due to SA node, it beats P wave is due to SA node. QRS is due to escape rhythm, and there is no relation between the P wave and QRS. It is not the P wave that is causing the ventricular depolarization or QRS. QRS is due to escape rhythm. P wave is due to SA node. Both are different, so there is no relation between P wave and QRS. So what happened is P wave can occur before the QRS, or P wave can happen with the QRS, or the P wave can happen after the QRS. So P wave can occur anywhere, even before the QRS, during the QRS, or after the QRS. And the PP interval and RR interval always remain regular, and there is no relationship between p wave and qrs. Number of p waves are obviously more than number of qrs, because p waves is due to SA node, and that SA node and impulse generation by SA node is much more than the impulse generation due to escape rhythm. So let's summarize the key features of third degree heart block or complete heart block. First one is low heart rate. As we discussed here, the ventricle beats from the because of the impulse generated by structures below AV node, maybe from the ventricular wall or maybe from the his bundle. Whatever the structure that generate this impulse, those rate, the firing rate is always going to be less than SA node. SA node has a higher firing capacity. So the ventricle, let's say, beats anyway less than 60 beats per minute. So low heart rate. Another feature is the PP interval. PP interval is going to be constant. P wave happen at a regular interval. Similarly, QRS complex will happen at a regular interval. So the RR interval is also going to be constant. But there is no relationship between P and QRS or R wave. Why? P wave is because of SA node, QRS is because of escape rhythm. No relation. P is not always followed by the QRS. P is because of SA node and QRS is because of ventricular escape rhythm. So both are different. Both these waves are generated due to different structures. All right. So these are the important features of third degree heart block. Now let's see an image. This is an ECG of complete heart block or third degree heart block. If you look at this ECG strip, you can see here I have already marked this P wave. Can you see? The P wave is happening at a regular interval, but this P wave is not followed by a QRS complex. So an RR interval is always going to be constant. 1, 2, 3, 4, 5, 6, 7, 8. The distance between R, that is RR interval, is about 8 large box. Here also 1, 2, 3, 4, 5, 6, 7, 8. Again 8 box. So R wave happens at a regular interval. Similarly P wave, but there is no relation between P and this QRS or R wave. Another what are the other features? Low heart rate. Let's see in this ECG. So this is an R wave, this is another R wave. 1, 2, 3, 4, 5, 6, 7, 8. So 8 large box between two R wave. So the heart rate, that is 300 divided by number of large boxes between R wave. So it is going to be 8. So this is going to be approximately around between 30 and 40. So bradycardia, low heart rate, P wave, multiple P wave, and R wave. The interval RR interval is same, P interval is same. No relation between P waves and R wave, and always the number of P waves are more than QRS. Please note down this as well. P waves, number of P waves are always going to be number of QRS because P wave is due to SA node and that has higher firing capacity compared to QRS due to escape rhythm. All right. So yeah, we have finished all the types of heart block. Now, uh, when it comes to management, you, you can see here Mobit's type 2 and complete heart block, third degree heart block. This require pacemakers. But in the beginning, we don't give pacemaker. because these patients are going to be unstable. Inserting pacemaker is an invasive procedure, so in the beginning, to stabilize this patient, we give atropine. After that, we give the patient, we will attach a transcutaneous device, transcutaneous pacing device, then transvenous, followed by, then we will insert a permanent pacemaker. So that's about heart block, three different types: first degree, second degree, third degree, and the management for two types, that is Mobitz type 2 and complete heart block. Other types of heart block, we don't need any treatment. If the patient is symptomatic, we will follow the same protocol: first atropine, followed by transcutaneous, transvenous, and permanent pacing. So that's it. That's all about heart block. Thank you.